has been very, very helpful recently with best doctors as we try to kind of come up with a greater sense of definition around diagnostic accuracy. Dr. Schiff has played a leading role both with the AHRQ and a newly formed Society of Diagnostic Accuracy, along with some leaders about trying to root out kind of some root causes as to why diagnostic errors occur in the first place. So it gives me great pleasure to introduce Gordy to our group. So Gordy, please take it away.
There. Dr. Schiff? Oh, hold on for a second.
We're working on trying to get the audio going here, and we'll get it up and running in a second.
How about now? Are you able to hear me?
Yep, we can hear you loud and clear.
All right. You wanted to mute me for my hour talk. That doesn't work so well. Actually, so that's a sound check. How about a time check? It looks like we're still a couple minutes early. Should we worry about that, or is everybody who needs to be here?
Well, we're about 1 minute early.
Should we wait till at least the hour? I know
sure,
you must have.
Sure, that's fine.
Yeah. And thank you for the nice introduction and
sure.
Exciting. And we'll try to make this interactive. I guess somebody there will unmute people as they request speak. I love to be interrupted during like a lecture, but probably it'll work best if we just go through the slides and then let people hold their comments till maybe 35 minutes. We'll try to open it up to 35.
Great.
Okay, and still seeing we have another minute before the hour, so why don't we wait if anybody else is going to be picking up.
That sounds great.
Folks, do you usually expect or get for the attendance?
I'd say we get anywhere between 20 and 45 coming. We
Great.
Already have about 20 on the line now.
Great. When it comes to diagnosis, timeliness is everything, right? So that's just what we need.
Dr. David Harrison has just joined us in the conference room here.
Hey, everyone. Hey.
Hi, David. Yes.
Hey. Good to talk with you, Gordon.
Yes, I'll just start by just preface, and then I'm sure we'll be in the hour and ready to go. This is really very exciting and special for me to be working with best doctors. I think to see this where it's sort of the start of what I would think is a very fruitful and hopefully long collaboration. We make all the work that you all are doing and in collaboration with tools you've developed and insights and tools that we develop, some of which I'm going to share in the next hour. We're going to really not only help the patients one-on-one the way that you are doing every day, but hopefully really make a contribution to understanding and preventing and mitigating diagnostic error, because I think it's a sort of a new field to plow, even though we talk a lot about the diagnosis and being central to what medicine is about. The field of diagnosis errors, as opposed to, for example, medication error and patient safety, is really very underdeveloped, and we're going to hopefully advance the state of the art, including right now. So, you ready to go, Lou and David?
Absolutely.
All right, good. So again, no conflicts to disclose. I work a lot currently with the Risk Management Foundation of Harvard, CRICO, who I think insures some of you all, and I even see that as a cross-fertilization, but no financial conflicts other than telling you that I do spend some of my time looking at things from their end and really how to improve ambulatory safety. So where we're going to go today is the line that you see on this next slide. Really talk a little bit about what the scope of the problem is. The importance, I think, to that is not necessary in this audience. But about sort of what and where errors occur. Thinking this question of diagnostic errors being cognitive or system errors, and sharing you with some of the data from some of the cases that we collected in a study we published recently, a couple years ago, in the Archives of Internal Medicine, and obviously begin to sort of explore some of the ways we're going to prevent and listen the problem of diagnostic errors. And I'm going to just touch down on a few that I've been here. We're interested in improved documentation. Really interesting because I think that's part of what your core business is getting documentation or better, thinking about how we present information, follow-up and feedback, another area of interest, and hopefully low-hanging fruit in terms of improving diagnosis and even thinking about the role of the patient. So first is really asking the patients, who I think are the most knowledgeable in experiencing these types of errors. There was a Gallup poll done, this is now almost a decade ago, but I doubt it would be any different, saying review had an error reported in some type in the course of your medical care. And the interesting thing was, even though most of the efforts in patient safety are in the preventing the wrong leg from getting cut off or medication errors, CPOE, by a factor of 2 to 1, diagnosis errors were the most common type of error that patients or a member of their families state they experienced. And so patients know this is a problem and know that they've been given wrong diagnosis or diagnosis have been delayed. Another lens to understand the importance of the problem, the magnitude of the problem is, as I mentioned, the malpractice lens and angle. And look at the cases that CRICO, which for those who don't know is the malpractice insurer, the non-for-profit malpractice insurer for the Harvard hospitals and affiliated practices, it's out that diagnosis errors, both in terms of numbers of claims, that's the green, spring green here in this slide, and the blue, total dollars incur, far and away dwarf treatment errors, surgical errors, and you hear about these big surgical settlements. You hear about OB cases that are profile. It just comes to total number of cases and claims, diagnostic-related errors, and again, especially in the outpatient realm, are leading order of the day here. And so this is really what I think justifies us trying to focus on this, spend time and energy thinking about how we're going to do better. And one interesting thing is when you break down the diagnostic errors, especially the outpatient diagnostic error cases, and I think this is a year summary. Yeah, this is from 2004 to 2009. Cancer by a factor of 10 to 1. You see, again, we think of heart attacks being missed, etc. Be sent home from the emergency room and dying, and a malpractice suit ensuing. But cancer diagnoses are much more prevalent and much more common as the types of diagnoses that are missed in these malpractice allegations and cases. There's big four in these repeated studies: colorectal, prostate, lung cancer, and breast cancer. From year to year, in terms of the CRICO data, other data, those are among the top four, and continue to be problematic ones we'll mention. So I put this slide up. It's both a beautiful and a horrifying picture of a cancer cell dividing and electron microphotograph. But certainly nobody on the phone here, at least certainly I don't, know how to diagnose cancer when that first cell abnormally divides. So, and you could say that every diagnosis of cancer is a delayed diagnosis. But I think what we're really trying to think about is how clinically we can pick this up at a more timely stage. And the way we go about understand diagnostic improvement, I back to somebody who I actually got to personally know in the later years of his life, somebody by the name of Avidus Donabedian. Actually allowed to vote here. How many people heard of Donabedian? Is that something we didn't explain to people how to raise their hand, right? Is that our you raise your hand? How many people heard of Donabedian?
I think we have that functionality.
I think that we do.
I think that we can set that question and people can vote on that.
Right. Well, that'll be fun. Obviously, this is a talk about several people who both are heroes to me and somebody.
There's been a little bit of echo on the line.
Okay. All right. Anyway, just in terms of interactivity, but Donabedian is sort of known for a lot of work in finding quality. But one of the things he talked about, which often is not emphasized, although it's been increasingly emphasized in the Jake Commission inspections of hospitals, is trajectory studies, where you take a patient and track them through a particular diagnosis systematically, looking at the course of how the diagnosis and the quality of care was made. And this is a slide that I guess sort of changed my life. I think I've only seen a couple of cases of leishmaniasis, and I doubt that that's a leading diagnosis that doctors is covering. But what this slide really did for me, it was in the Annals of Internal Medicine, now we're talking 20 years ago, is they just took patients who were physicians requesting a drug to be released from the CDC, and then they tried to work backwards of how long it took to actually make that diagnosis. And as you can see from this, really a box plot here, it took something like a month or two, these are a number of days on the bottom, just to notice the lesion, to coming to consult the medical personnel, for the doctor to consider leishmaniasis. You see we're further along, we're into several months here, confirming the diagnosis, to actually start the treatment. We're talking about 100 days, 130 days on the average. So, and we should be able to push a button in our systems, and actually in your systems, with the data you're collecting, and I'm hoping to do this with Dave and Lou ultimately. And for any diagnosis, we should have a picture of how that diagnosis looks in terms of delays of diagnosis and where opportunities are. Hopefully you have something like a meningitis, we would be talking about hours or minutes, not days or months. But this information we could capture to be able to zero in and understand the delays at each point along the way. Another model that I think is going to be important for framing how to tee up our view and retrospective review and understanding of diagnostic errors with best practice data and the best doctors' data and the practices that you're looking at, is to understand this Venn diagram that we've created as part of a ARC grant. We begin to struggle. We met every week with cases. Every Friday, I just remembered what we brought in people who were physicians, as well as Arthur Elstein, who's sort of a cognitive scientist and patient experts, and actually non-MD people that were the most helpful in these discussions. But we looked at errors, and we found there's a lot of diagnostic process errors. If we were to take a drug history, somebody has a cough. Again, I'm just using very obvious ones. Somebody with an ACE inhibitor-induced cough. Doctor doesn't examine the abdomen and abdominal pain. Blood samples get mixed up. A corn lesion is on an X-ray. It doesn't get followed up. And what we call diagnosis failures, which is misdiagnosis, delayed diagnosis, and misdiagnosis. I think really misdiagnosis probably could be reserved for autopsy, because ultimately every diagnosis is delayed and it's found except for something that's found later. And obviously what we really care about is what impacts negatively on the patient. This intersection of these three Venn diagrams. So on one hand, you have things going wrong, leading to a wrong diagnosis, but nothing goes wrong there. Blood sample is switched between two patients. Somebody said possible hyponatremia when they're not, but nothing bad happens to the patient. This is obviously a different horse of a different color. We've seen cases where pathology specimens were mixed up between patients, or perhaps they were misread, as you were not infrequently finding. Diagnosis is made, so they get into that blue part of the Venn diagram, and then somebody has a bilateral mastectomy erroneously as a result of these process errors. So with this conceptual understanding, I want to go into sort of some quotes and with moving forward to improve on diagnosis, starting with Don Berwick, who I think you do know, former director of CMS and IHI. And he said in that august medical journal about a day ago, I saw this quote. I really have never seen him elaborate on this, but I think I share this perspective. It says, genius diagnosticians, great stories, but they don't make great health care. The idea is to make accuracy reliable and not heroic. And it'd be interesting to spend some time pondering what that quote means for you guys. I mean, you are best doctors, great doctors. You're not heroic diagnosticians. I think the stories that you have in terms of making diagnosis more accurate and reliable doesn't depend on a brilliant diagnostician coming up with something that nobody thought of, but really thinking about how to hardwire in a systematic way close some of the Swiss cheese holes that you see here. And again, we could spend time on each of these aspects of diagnosis, but in terms of time pressures and distractions and signal to noise, problems training and prior experience, limitations that doctors might have who are trainees, and all the micro environment things from the AT support, time pressures, support system. So the little person whose sort of face I think is worth putting up here, partly because he's a sort of a local hero and a legend and a leader in patient safety and a personal hero of mine, and is Lynn Leap, and the father of patient safety, but partly because of two important concepts that he's embodied in these next two quotes. The first one is the idea about blame-free versus blaming people in the culture of safety. The single greatest impediment to error prevention is that we push people for making mistakes. And so the fact that we can look back, hopefully you're doing this all the time, where errors occur, and really feed this back to people, using this for learning and improvement rather than punishment, whether it's suing them or taking a license or for performance incentives, barking up the wrong tree. This idea is really to use error as an opportunity for improvement and learning. And how does one do this? Safer practices can come about from acknowledging the potential for error. So we have to admit that error is human. That's the title of that report. That's the idea behind thinking and understanding. We all make mistakes. There's Swiss cheese holes everywhere. That diagram of process errors is just work with systems that are full of those. So we need to acknowledge the potential for error and then building an error reduction strategy at each stage of clinical practice. So we went our writing meetings and created this taxonomy of where and how things can go wrong. We actually start out by trying to figure out why the diagnostic errors occurred, but we're immediately sobered that we so much disagreement, we weren't sure, we didn't have all the information we needed in many cases. So we took a step back and we said, well, let's just at least, if we can't figure out the why, let's figure out the what and the where, and at least begin to classify these errors, put them in these bins that we created as this taxonomy, and now has been used in a number of published studies by different groups. Hardeep Singh his group has used our taxonomy as well. But so number one, access and presentation. Obviously, there can be delays in diagnosis if somebody doesn't get in for whatever reasons. Failure in the history step. A piece of data is not elicited. It's not given the right weight. It's not followed up on. Similarly with physical exam. The testing stage, people usually talk about different stages in the testing process, but we divide into ordering performance of the test and then clinician processing. So obviously if a pathologist erroneously reads a pathology specimen, then that's something, again, that you're familiar with. It would fit into that part. The order stage, if somebody orders the wrong test or a unnecessary test, failed follow-up of a diagnostic test. This is something I'm particularly interested in because, again, I think it's one of the lower-hanging fruits, but even such a simple thing as ensuring that an abnormal mammogram or X-ray gets followed up on is not, or a PSA is not a simple thing to high reliability at the Six Sigma where you have the specimens potentially getting lost. The hypothesis generation, suboptimal weighing, and then we added another. Those come from really Jerry Cassier's work here. You consider the diagnosis. That this conceptual model. He published cases in New England Journal and has done some studies helping conceptualize those as sort of the ways to think about this. But also, I would add recognizing the urgency and the complication. You really don't know this person has coccal meningitis, but you recognize they're sick and you don't send them home as a kid with just a nothing fever. So the referral and consultation stage is another place in the diagnostic process as well as follow-up where things can go wrong. So we went and surveyed physicians in the course of rounds and at a number of hospitals and asked them to report errors. So this isn't Big Brother coming along saying you screwed up and we're going to point the finger at you and them saying, no, I didn't, and how do you know I made a mistake? I don't think I did. These are people sort of self-confessed, if you will, errors that we asked them to report anonymously to us, and we collected these. We got a total of, we asked 310 physicians to give us 3 errors each, or if they up to 3 errors. And one thing we said is these could be errors that you've made yourself, or errors made by others. We were assuming we'd get most of them that they would vividly remember on the spur of the moment, things that they had personally committed, but as you can see here, 2/3 of them were actually errors that they saw, quote, others commit, whether that was reluctance to self-criticize or scrutinize, even though this was anonymous and safe, or whether this is just what people are seeing and remembering. These are the types of diagnosis. Interestingly enough, it pulls the malpractice spectrum here. When you add up lung cancer and colorectal cancer, breast cancer, you do get cancer again as the leading type of diagnosis. Again, these are familiar bread and butter: pulmonary embolism, drug reactions, adverse drug reactions being overlooked or poisonings, breast cancer delay, fractures being missed, etc. Again, we're very interested in seeing how this compares to your all data. We're going to we're in the process of beginning to do this and figure out how to do this and how this compare and contrast. What are the differences? What are the insights from your work? Again, these are some lower numbers in our 583 cases. But again, spinal cord compression is, you could say, wasn't very frequent, but just the fact that there were 6 cases that people reported, again, that can have devastating complications with if delay is not if there's delay in recognition. I won't spend too much time, but we pulled out in these next few slides a couple of 10 of the more interesting illustrative cases. Somebody had opioid intoxication, it wasn't considered, and it wasn't a differential. Renal failure, people had serum chemistries switched. Suicide, overdose with valproic acid. They only drew the initial level, which was not sufficient to catch the rise where they had a lethal blood level. Pulmonary embolism, as we saw, led the list. Symptoms were misinterpreted as pneumonia. Acute appendicitis, the radiologist misread the ultrasound, the CT scan. Various other things here. Long-standing anemia was never worked up, and so this myeloplastic anemia was not diagnosed. Colon cancer, somebody presented with hemorrhoidal bleeding. We see this a lot in the CRICO data. And the person was presented with rectal bleeding, and it was assumed to be hemorrhoidal, and of course there was a colon cancer that was not properly timely diagnosis made. With our data, where is the in the diagnostic process using the taxonomy? We had lab and radiology testing stage along with assessment being the dominant ones. Very little, at least in terms of what people reported, was presentation or follow-up, history and physical. I think this is a little bit distorted by people are looking back on this, but because history and physical are important, but in terms of where the errors were occurring, and again, in the specific steps, failure to consider the diagnosis in the first place. Be interesting, and we've talked with Lou and David about how likely and often we're going to find that you're going to make a diagnosis and nobody was even considering it versus we wrestled, was it A versus B, and they made a mistake in saying it was B when it was A. But in these cases, we went and coded them using our taxonomy. This was a factor. This is one of the things that leads us to think that maybe some kind of clinical decision support, which would help prompt people to consider diagnoses in the future, be something that would help. If you're in ordering a needed test, obviously these are overlapping. Many of the cases have multiple factors. Too much weight on a competing diagnosis, so somebody with rheumatoid arthritis and they present with a swollen joint. It's it's you relate to the pre-existing rather than they not to have a staph infection of their joint. Failure to delay in test result, again, not the highest, but still what I think is an important and lesion here in terms of making improvement, etc. So one thing that I would want to ask, because I'm sort of a systems guy, there's people like Pat Crossberry who put a lot of their work on cognitive errors, and I actually think sort of a false dichotomy. So when you say, well, the failure to consider, that's a cognitive error, but what did the clinician fail to consider? Did they get interrupted while they were doing their differential? They didn't have enough time in the first place? I'm telling you, if I have 5 minutes to see each patient, I'm going to make a lot more errors in diagnosis than if I have 15 or minutes to see patients, complicated patients especially. Lack of knowledge, I don't have enough know in the first place, or was relying on memory. I didn't elicit some key symptoms. Are these, again, cognitive problems, or are these system problems? Or is this a rare atypical diagnosis, or I've been thrown off? So really, erase that question. What are the causes? What are the remedies of these so-called cognitive problems? And I think many of them really rely on making more reliable systems, as Don Berwick's quote yes. So where do we want to go with this talk today in terms of preventing these? And again, we just throw these bullets up, and we're going to not touch down all of them, but superficially a few. Multiple test follow-up, again, we've talked about that. Re-engineering clinical documentation. David Bates and I published something in the New England Journal, which we're going to talk about some of the ideas we've raised in that in a moment. Patients follow-up, calling patients. We did some projects with the University of Alabama where in 3 days we had IVR systems, these automated telephone call people to see if they were better and following up if they weren't, because we'd be missing a diagnosis, misdiagnosis. Diagnosis timeout, where we figure out ways of pausing and reconsidering the diagnosis. Knowledge, and then enhanced role for the patient, that we're going to talk about that. So this is a popular book. It was sort of a #1 bestseller, I think, the New York Times. Jerry Groupman is a local BI doctor here. Several of you probably know him. So I'll say that this is the better way of framing it. Do doctors think? But Groupman also is very much on record is saying electronic clinical documentation is part of the problem. And I guess what I want to argue for the next few minutes is I think it's part of the solution. He talks about these new electronic records, and I think we've reached a tipping point, certainly in Massachusetts. More than half of the practices are working with electronic records. And Groupman's critique in the next few slides, I've just quoted from his New England Journal article, fit yes, useful no. We're manipulating things, pasting notes from everybody else. Notes are meant to be focused and selective, have become voluminous, templated, distracting, takes away from the cognitive work, might be efficient for documentation, but not for creative thinking. You have a sea of results here, trying to find what's new with the patients, like where's Waldo, one physician bemoaned. Electronic records have become a vehicle for protecting misinformation, and actually we're going to be very interested to see how much that in the data you're seeing. Somebody is given a label and somehow it just carries with them erroneously. Problems are going to worsen with time pressure, billing, lawsuit requirements for documentation. The worst kind is filling in these check boxes rather than just having a dialogue with the patient. And an open-ended narrative, you have a checkbox checking, and then templates. They constrain clinical thinking, promote automaticity. The computer is becoming a barrier between the doctor and the patients. We become slaves to the technology rather than working for us. So we kind of thought about what Groupman and wife argued in that, and David and I wrote this piece. And I'm just spend a few of the remaining moments walking you through something that we want to think about, turning those arguments a little bit on their head, and not necessarily saying there isn't some truth to what Groupman said, but really thinking about ways that electronic clinical documentation could be and needs to be part of the solution rather than part of the problem. And again, I'm going to go through these bullets fairly quickly. although eager to come back or talk or have anybody get the reprint of the article or request it, and we can talk more. One is providing access to information. I think I've practiced in environments previously where were paper charts and we had to request them and look through things to find needles and haystacks, and old records can really appreciate that qualitatively in a different era. I think information overload is actually more of a problem than not having access to information, and we need to figure out ways of selectively being able to pull in information quickly. Discussion, but I think the point is pretty obvious there. The next is to really be able to record our assessments, and boy, would I have several hours talking to you guys about what you get of reading the assessments of these doctors and clinicians, and where they're helpful, where they fall short, where their thinking is spot on, where their thinking is inaccurate or skimpy. But my way of thinking about these records is CYA. People think about covering your ass for documenting everything, but I like to think of the record as a canvas for your assessment. That this is space where the physician should basically be thinking out loud. First of all, for them, and the next time they see the patient, but for other caregivers and having ways of thinking about what's going on with the patient and reflecting that, and if nothing else, helping best doctors when they come along and try and look at these charts. Maintain a dynamic patient history. So here we're talking about copy and paste, and where does that belong? I argue that there's certain information that should be copied forward, carried forward. Something an amputated leg, or a mole on their face, or another physical findings. One just be verifying that. Shouldn't have to be writing these things from scratch, but how to do that in a way that's both honest and efficient, accurate. Problem list. I would say, and again, I'd be interested in your all opinion, that the problem lists are one of the greatest health IT failures, health information, forget about information technology, just information failures. They weren't accurately maintained on paper. They're not often being correctly or accurately maintained electronically. We haven't really figured out how to integrate them into the workflow, but I think this is a crucial need, and again, would help you when you open a chart to just get oriented to what's going on with the patient as well. Tracking medications, medication reconciliation is so complicated. The Joint Commission abandoned its requirement for this. Again, a long discussion, but as far as diagnosis is concerned, you're just making accurate diagnoses of medication-related problems if you don't have an accurate list in front of you, and as well as a prompt of what adverse effects to consider. Tracking tests, I think we've talked about that a fair amount, but how to integrate that into the documentation workflow. Ensuring continuity and coordination. So at what point should I, as a PCP, be gathering together a lot of different notes of different consultations that the patient's been to, and just and figuring out how to synthesize and summarize and consider this so we don't overlook problems that could be explanations for multiple system findings. Enabling follow-up. I think we talked about up on patients after because there's a lot of uncertainty in diagnosis, but the way to deal with that is obviously to be honest with the patient and get good follow-up, see how they're doing in a week or a month, and following up on what we're reading about. Back to clinicians who make a mistake. So we had a patient who died in the ICU during one of the projects we were doing of CMV, disseminated CMV. He was a compromised host. I went back, and there were something like 35 doctors who cared for this patient in the 3 months that he was in the hospital. And I'm talking about somebody who got called in the middle of the night to give Tylenol, acetaminophen. I'm talking about people who really, it was their patient for a month, and they were the ID attending, etc. And we went back, and of those 35 people who cared for this patient, who ultimately was found on autopsy, the disseminated CMV, how many heard about this as the final diagnosis? And the answer was 3 or perhaps 4. So 90% of the doctors never even heard what happened. And I'll have examples of patients, you see somebody in the cafeteria say, hey, remember that guy you sent home? from the ER last week or the hospital. Guess what they turned out to have, and that's sort of a miss method. Could the electronic records create a more systematic method for feeding back? Create a placeholder when somebody's interrupted. Longer discussion, but somebody's in the emergency room, there's a cardiac arrest in the next bed, they come back to the patient, where was I? Just trying to do that in a more organized way. We do that with computers all the time. We leave an email half written, we can come back to it because the web's still open. What's the other part in medicine? We talked about these checklists as a way of reminding people and maybe systematizing so we're not relying on human memory anymore. Lucia Leap and I recently published are thinking about this, that there's probably a half a dozen places where a checklist in a diagnosis and automating that with a computer could be beneficial. One is essential data elements that could just be collected by the computer on every patient, so we don't have to do this manually ourselves. Don't miss, and remember to do it. Don't miss diagnoses. So we would be considering things in certain situations, even if they're rare, so to make sure we are prompted to consider these. And then red flag symptoms. We all know this typical red flag constellation, somebody with back pain with either fever or cancer patient, that there might be an abscess or metastases. So one of those things that we could be prompted. Potential drug causes, I alluded to this, but somebody has thrombocytopenia and they're on a certain drug, that there should be saying, hey, did you consider heparin as the person's on heparin with their counts falling? You say, well, every doctor should know that, but that's we're talking about making this reliable and 100% reliable and less relying on what good doctors know and don't know. And remember, on the spur of the moment, referrals, so this would sort of create a flag to ensure that, and then patient follow-up. So somebody home with a fever, what should they watch out for that, and this in an automated way so the patients have this in front of them. Checklist, in terms of thinking of things to think about, this is done by my colleague John Eli, and we helped maybe let's add the don't miss and the often missed diagnoses to this checklist. So often missed is depression and anxiety, and don't miss is because it's something that's more treatable. Celiac disease is sort of a don't miss diagnosis that we want to put in that. I would say that this is not an evidence-based list. This is sort of a consensus of a couple of people thinking about this, but we need some more evidence-based to see not what should be on the list, but how useful it is. Last slide here in terms of this, a couple more after this, and we'll throw this open for questions. In terms of the role for electronic documentation, doing some of the Bayesian calculators in terms of sensitivity and specificity doesn't just really apply only to testing, but even to clinical prior probabilities and bias probabilities to make sure that the subjective estimates that we're doing now, which have been shown to be unreliable in terms of consistency, could be done more consistently and automated. Ask information sources, so our residents push a button and they can look up to date the discussion of the differential diagnosis. There's a lot of that happening already. Second opinion, so I can, and then dermatologist appears on the screen and takes a look at the rash and tells me what I should be worried about, or if the patient needs referral. Doing this just in time to make sure that it's easy. There's a low threshold. Many people are thinking about how to make it harder for people to get to specialists, but I think those kinds of instant opinions, if done right, and you are thinking in this mode as well, it can really be beneficial and really quite cost efficient. And then find the holy grail, increasing efficiency. So we doctors are feel very burdened by documentation and the electronic medical record. If I get up here and say, well, this saves you a lot of time because you can use a computer to write your note, I would be laughed out of this WebEx space. People are spending a lot more time. They're going home. I personally have to do several hours of documentation after each clinic, but it ain't all this way. There's a piece by Isaac Kohaney and Ken Mendel in this week's New England Journal of Medicine that says we're way behind other industries in thinking about how to make this more efficient and using some of these more smarter tools, and I think there's an imperative to do that. So again, we have diagnosis as this open loop system that we get this feedback. The water goes on every day, whether it's raining or it's flooded, and we really need to be learning from our mistakes. That's what we're hoping to do with working with best doctors. Those of us who are in diagnosis here, that's what you're doing on a sort of a smaller scale level in one-on-one case. And this is the last slide. Does the patient have a role here? And again, I'm saying role, not responsibility. For us to say it's the patient's fault that they didn't come in on time, or they didn't tell us everything, or they're noisy patients, that they've got a lot of non-specific complaints that keep us sorting out the wheat from chaff. That's not the patient's responsibility, but the patient can be helpful. They're a partner here. So I think of this term co-production of diagnosis. It's not the doctor that makes the diagnosis. It's the doctor and the patient working together. And some of the components of this that we've bulleted on this slide, one is obviously they have to try to get in a timely way, even if it means pushing through the front desk and saying, no, something serious is going on that we need to be seen today. Being an observer for the symptoms, accurately describing them, being reliable in terms of follow-up, helping know when we haven't gotten back to them on tests, their hunches. Do you think I just came back from Mexico? You think that could have anything to do with this wish I have? Your own doctors have mixed views of this, but I welcome kind of backseat driving from patients. They want to take a look at something. They should avoid some crazy internet sites, but I'm free to read up and give me your hunches and be thinking of this together. I'm not threatened by this, or try not to be threatened by this, because patients need to be engaged. Being patient with time and tests, so we don't need to rush to an MRI for everybody who has an ache or a pain or even an ache. Getting family to support us in terms of supporting some of these other functions, respecting limits on staff, time, and resources. Agree to disagree. You think it's something serious, I don't. Let's acknowledge that we don't agree, but let's keep the door open for both possibilities. Building trust and communication, and even we need patients to be involved in the patient safety movement and the diagnosis improvement efforts. So what will take to provide or institutional level to support these roles and help them flourish? That's a question we think about a lot in terms of giving some gas in the tank for this patient safety movement. So this is the conclusion. So we want the patient involved. Nothing about us without us is for us. This is from a New Orleans community group that's part of Rebuilding New Orleans, and so we need to kind of build the diagnoses, definitely including the patients as well. So please throw it open to, I think we'll stop there, to our mod for some questions. How do we do that for the next 15 minutes? Yeah.
Some questions everyone should be able to answer.
Thank you, Gordy. I think that was a really full talk, and I think it's, I think definitely you've sort of you've cast a large net here in terms of just so many topics. One thing that I was very interested in your list about all of the things the electronic medical record might provide, and one thing along with problem lists are really rare. The other thing that I see that is not really particularly clear in any electronic medical record are really important patient preferences. So, there are these that patients basically have over time, like, I don't want to have any colon cancer screening, I don't want to give up smoking, I don't want to take insulin for my diabetes, I don't want to consider a surgery on my back, that are very important, but often really get at the patient preferences. It's no place in the record that really, and these are not just, topics of the moment, but these are important topics that really do impact the patient's overall health over time. I don't know whether you've you think that should be another thing that should be somehow codified, and it give a little bit of focus of things that you might want to talk to the patient about on the next visit.
Is he muted?
We muted you accidentally.
Right?
Sorry about that. You're back on.
So talk about casting a broad net. Thank you. That you really touched on a lot of things that I could probably use the next 20 minutes for sure. But to be very brief and touch on a few because I think these are really interesting, important aspects. I mean, I think I heard there was a drop of noise. You're saying you're looking at problem lists and you're finding the same problem with the problem list that I'm finding, and it's not just a matter. There was a time I was a director of our general medicine clinic, and JACO was coming by, and our problem lists were no good. I paid people a quarter for every problem they add out of my own pocket, and it's just to sort of we used Post-its, and it was in retrospect a pretty pathetic effort. And the idea again is not to have these problem lists polished up for JACO or anybody that sort, but really to figure out how to integrate this into the workflow so we don't lose track of problems. I mean, there was a New England Journal case that was published from Tejo Gandhi. Somebody had a splenectomy, and that got but in that case without a pneumococcal vaccine, which they ultimately died of pneumococcal sepsis. So we need problems to keep problems from getting lost. There's an unexplained anemia. That light should keep flashing. Or even if we explain it, even if we think the person probably just has thalassemia or iron deficiency, the problem shouldn't get lost. Because again, many of these problems or symptoms need to be reconsidered or in light of how things evolve. So, problem is, and frankly, to me, it's to make my workflow more efficient. And thinking about how to do that, I think we need sort of a construction team to think about how that's going to work. The way it works in my current system, which the way LMR, it can be worse in some ways. It's so frustrating the problemless functionality, but I won't go into it in detail. So just to address the patient preference thing, I'm hearing noise here. We can come back to that. Make 3 or 4 points in relation to what you're saying. First of all, we definitely want to know our patients well enough to know what matters, what's important. First of all, to be good diagnosticians, we need to sort of have the social context of what's going on with the patient, what's happening at home, what are the home situations, even what are the environmental factors that we need to consider. But the patient preferences and concerns, and again, this shouldn't be just a CYA kind of thing. The patient refused colonoscopy, so that's the end of it. Which, by the way, the courts have ruled that's not enough to just say patient refused, and it's no longer my responsibility. I'm really looking for you to say family history of colon cancer. Talking about ordinary screening, we want to be more insistent and stronger to try and make sure you do get screened. And preface again is really there to be able to have a dialogue with the patients and have a trusting conversation. To be able to have a starting point for being. I know you don't like insulin. We're not make you use insulin if you don't want to, but so I'm going to respect that. But I want to also let you know what your risk benefits are, and I think you need to just have that information in there to be able to have this. And he actually add one other thing. We're talking about preferences, but another word is concerns. What is the patient concerned about? And it may or may not be something important diagnostically, something medically. But I think unless we really know that that the patient is concerned that it's impossible to get in to see me. They've been on the phone, for 4 hours on hold, and that's their concern. Obviously, that goes into the access part of diagnosis. What concerns? Their mother died of breast cancer. Could it be them? Or brain cancer and they have a headache? These are all going to be concerns that are important for how much weight or how much concern we have, with what patients are saying. So, preferences, concerns, patients with them, and again, The problem is it's mostly being driven by the lawyers rather than making these records work for us to do a better job and be better doctors. And I think we're going to have to not do this as an offensive thing, but as an offensive thing. Again, not against lawyers, but offensive in terms of making ourselves better diagnosticians. First and foremost, not relying on human memory. I just about to turn 62. I don't know how good I was when I was younger, remembering everything, but I don't remember everything now, and I don't think the heroics that requires remembering everything, whether it's a differential diagnosis or whether it's a question to ask, whether it's a fact about a patient, we're going to need some help, and we want to have reliable to do that. So that's a very superficial, quick answer to a very big question. That I think that was Lou who asked that, right?
Yeah.
Okay. Let me see. Anybody else? Other ones want to jump in, please.
Anybody? Is there unmuted?
Well, it's David. I want to ask, and this is something we had talked about previously, what kinds of conclusions your group, when you had this working group about diagnostic error, what conclusions they had come to in trying to establish gold standards for diagnosis? Because to say that a diagnostic error has occurred, often one has to know, well, what's the right diagnosis? This thing I think that we struggle with at Best Doctors, because we talk about we change 20% of diagnoses, but how do we know? We have one physician who says the diagnosis is B, and the doctor said the diagnosis was A. So he said we've changed the diagnosis, but again, there's no way knowing a priori that the expert right just by virtue of being having been the person commenting on our interconsultation. So, and of course it's different for different conditions. But is that issue of gold standards for what really is that right diagnosis something that your group had addressed?
Yeah, good question, and I know we've struggled with it in talking to you guys too. And we're interested in this, and by the way, David and Lou have been very keen on using this dialogue around this diagnosis errors as a way of doing diagnosis errors, figuring out what diagnosis errors Best Doctors is making, because there's a finite rate that you're going to be either suggesting or claiming is the diagnosis, and you're going to be wrong. Hopefully, after all the careful deliberation and what we would call the diagnostic timeout, your rate of your rate of diagnostic errors is going to be much smaller. But those I think would be that gold would be very valuable. So you're asking by what gold standard does one say this? So I would say there's three things. General realms, and again, you have in all of them, but let me just talk about that. The first one is really the clinical course, right? So if somebody has a headache and you say it's nothing, and the workup is negative, and then they ultimately develop a brain tumor, then now it doesn't mean that somebody just couldn't incidentally develop a brain tumor unrelated to the headache and the initial complaints. But the point I'm saying is, clinical course is really the ultimate gold standard. This patient with CMV, dominated CMV, the initial workup was negative, and people considered CMV, but ultimately a diagnosis was made with, in his case, after post-mortem. So what is the test of time? And that becomes a gold standard. Again, how something evolves clinically. The next gold standard, I guess, would have to be an expert gold standard, and that's one you guys rely on a bit. Certainly at this point in time, putting three people together and just saying, based on clinical criteria or expert opinion. We've talked about re-reviewing some of your cases, and I'm really excited about the possibility of doing that. Today, if expert 2 looks at the same case, are they going to come up with the same answer? So, but hopefully So that's another gold standard, and you hear me saying these are kind of soft. They're tarnished in the sense that one is sort of the ultimate. And then we have diagnostic testing as another gold standard. All right, is there a definitive test? Sometimes these definitive tests aren't going to come along tomorrow rather than today. We're debating, if somebody can do it tomorrow that wasn't available today, is that a diagnostic error? Obviously, the diagnosis was incorrect. Did somebody do something wrong? I think that's why this Venn diagram, which I'm going to jump back to, for me is so helpful in trying to, I wouldn't say sidestep this, but really engage us in a way that really works better. So if you look, there's obviously a diagnosis failure. There was a diagnosis that we failed to pick up. Did somebody do something wrong? There wasn't a test available to pick it up. Can we identify any of the things in the diagnostic process that we, in our taxonomy? No. So you can have somebody in the blue circle without overlapping, or the black circle or the red circle. But these are simply delayed diagnoses with the best things we can do, again, as unfolded by the clinical course, subsequent diagnostic test, or clinical experts thinking about this. But these things I said, I think is begging for more work. I think you guys are breaking new ground in terms of thinking about expert opinion and how expert opinion takes a case and reads it. And I'm sure you may have tough cases where your experts decide, I'd actually like to consult another neurologist to make sure I'm on the right track with what my thing is here. So I say those are the three gold standards. They're ones that I think we are only beginning to understand how to fully operationalize, and ultimately we want to figure out how to do it in a sort of a real-time, cost-efficient way. I don't know what it costs to work a case through best diagnosis. I don't know whether you publish that or give an estimate, an envelope, and it is from case to case. But it'd be nice if I could push a button and I could get a quick follow-up on a patient, so I could know what's going to happen in the future. We talked about that with our follow-up systems. Push a button and I've got an expert online saying, am I thinking about this case right, or what else should I be looking for? So how to make these gold standards both more reliable, standardized, systematized, and efficient, and figure when to activate some of them.
I think those are great points, and especially the cost.
I really ever put it quite together that way, so you helped me. I don't know whether I've effectively put it together, but I think that's my best quick response.
I think it's an outstanding response, and especially the whole test of time, because really the diagnosis at some point will declare itself in many patients' cases. Yeah. But I think for a lot of good reasons, our current follow-up system is more set up for immediate follow-up and not so much for extended follow-up. Again, a lot of good reasons and cost and all these kinds of issues, but which lends itself very well to reinforcing the impact of our services on an immediate time horizon. But in terms of looking from a more academic perspective at diagnostic error and how we impact diagnostic accuracy, the relatively shorter, let's say 3 months or so of follow-up that we perform is not always adequate to really achieve that gold standard test of time that you discussed. So it's very helpful.
Yeah, everybody's out there saying, the way we're going to get a better healthcare system is we're going to have patients shop around and we're going to undermine continuity, right? They're saying get patients to go from the Brigham to Beth Israel because you guys are more cost efficient. And so what do we do to undermining that continuity, and those longitudinal relationships, which I think are essential. Somebody told me recently who works at both institutions that Brigham's always looking for zebras and Beth Israel is more with the real diagnosis stuff. So I think that's an interesting anecdotal prejudice, if not a true observation. But how about else? We have, I guess, a few more minutes. Love to get another question or two in.
Wanted to, just slightly off topic. I have a cousin who's a philosopher out west and professor in Ohio, and I guess
you call that out west? Yeah. I'm from Chicago. Wait a second.
Yeah. And so a lot of his work is really around around how nature does not exist, and this whole notion of man versus nature and man's relationship to nature. And he goes into a pretty in-depth way about how he doesn't believe this whole construct of nature really exists. And it sort of reminded me when you were talking about this notion of, is it a cognitive error or a systems error, and how difficult it is to sort of unwind that if someone is having premature closure, but it's because they're running half an hour behind, and they did know about these other diagnoses, but they were really just trying to get through their office session as efficiently as possible. So is that a cognitive error, or is that a system error?
The patient was so pissed off about having to wait so long that they didn't even,
give a
good history. Yeah.
Right. And I guess, part of what's making the doctor so busy is that he's got to get, a bunch of authorization forms off to a pharmacy benefit provider, and he's got to argue with somebody about why a patient needs a scan, and he's got to finish up on some notes through an electronic medical record system that doesn't work. And I didn't know whether you felt as though some of these patient-centered medical home initiatives that are going on are really going to finally pull away in a meaningful way a lot of the junk that there's due today, for the sense that they will have more time to actually think about what's going on with their patients.
Yeah, I think it's a two-edged sword. Certainly teamwork is, and we've been actually doing some field research on patient-centered medical home. I'd love to come back and talk to you about what we did in some of these pilot practices. But teamwork is high on the list, and certainly things that doctors are doing that people could do. I know that medical home is totally conceptualizing this as a way of sort of off-dumping our work onto somebody else, but to the extent that we can think of more efficient ways of everybody's time, I think the promise of what you're saying could be fulfilled. I think on the other hand, one of the other things it might mean is you actually are going to be knowing your patients less. A lot of the time you're spending with patients, they're going to spend with other members of the team. Is that going to make you intimate with the patients, trusting, knowing what's going on with them? I think that'll be the trick, and because somebody's going to also come along and say, we want you to be managing a larger panel of patients with this team, and you don't need to see the patient once a year. You can see them only when they're sick, or only see the sickest patients. But we should just think about what the implications are there of that for diagnosis.
No, I think that's an excellent point, because I certainly know that there are patients in my practice who complain, and I've seen them a gazillion times, and as soon as they ever offer any kind of complaint, it always gets orders, because that there's probably something going on there, because this person, their answer to how you doing is always, I'm fine, and if they ever say anything, it's usually something non-trivial.
But all ears to you, but not to somebody who doesn't know that patient. Yeah.
That's right. Well, it brings us to the top of the hour, Gordy. I really want to thank you. We have the embarrassment of riches at Best Doctors, that we have so many terrific experts that are willing to come and speak at Global Grand Rounds, but I would definitely put this talk today really as, very much at the top of the list in terms of our Global Grand Rounds. It's really just has absolutely been fascinating and so central to what we do. So I just want to thank you again for taking time out of your busy schedule to kind of speak with us this morning. It's really been terrific, and our folks all around the world have appreciated it as well.
Well, Tanner, and again, for those of you in your group who aren't aware, Little David brought a group of us experts together a couple of months ago. We spent a full day, really, including Marty Samuels, who's sort of Ben is a neurologist and a great teacher, but the rest of us who do this diagnosis stuff day out, and we really slug through some cases, some concepts. I think Betters is really going to be one of the catalysts for moving things forward in this area. So thank you.
And I didn't know whether you shared your PowerPoint with Kelly.
Can I distribute? You distribute it? Is that the question?
Is it okay if we distribute it to the folks who called in today?
No problem. No, there's a few extra slides we didn't get to, but they're all yours to run with. Please.
Great. Thanks again.
Okay.
Thanks a lot.
Bye. Take care.